Welcome to Module 6, Depressive Disorders and Self-Harm. The major concepts we will discuss in Chapter 25 include the types of depressive disorders, such as major depressive disorder, persistent depressive disorder, premenstrual dysphoric disorder, and many others. We will discuss their predisposing risk factors, screening tools, and treatment approaches. We will review self-harm and suicide assessment in Chapter 16. Major topics include the mental status examination, the warning signs, and client education. Symptoms of depression have been described almost as far back as there is evidence of written documentation. An occasional feeling of sadness or downheartedness is common among healthy people and considered to be a normal response to life's everyday disappointments. Pathological depression is noted when the patient cannot effectively adapt and the symptoms they experience impair functioning. Mood is a pervasive and sustained emotion that may have a major influence on a person's perception of the world. Examples of mood include depression, joy, elation, anger, and anxiety. Affect is described as the external, observable emotional reaction associated with an experience. Depression is an altered mood that is expressed by feelings of sadness, despair, and pessimism. There is a loss of interest in usual activities, and somatic symptoms may be evident. Changes in appetite, sleep patterns, and cognition are common. A flat affect describes someone who lacks emotional expression and is often seen in depressed patients. The epidemiologic statistics of depression. Major depressive disorder, MDD, is one of the leading causes of disability in the United States. Depression is linked to an increased risk for coronary artery disease, especially in women younger than age 65. The prevalence of depression among adolescents are climbing. The reasons for this increase are unclear, but available data leads researchers to consider depression as the common cold of psychiatric disorders. Although the lifetime prevalence of depressive disorders is higher in those aged 45 years or younger, it is difficult to pinpoint a single age correlation because many factors influence age-related depressive symptoms. The gender difference is less pronounced between ages 44 and 65, but after age 65, women are again likely than men to be depressed. This occurrence may be related to gender differences in social roles and economic and social opportunities, and the shifts that occur with age. Some studies have indicated an inverse relationship between social class and report of depressive symptoms. However, there has yet to be a definitive causal structure relationship between socioeconomic status and mental illness. A number of studies have suggested that marriage has a positive effect on the psychological well-being of an individual. Other studies have suggested that marital status alone is not a valid indicator of risk for depression. Some of those studies have identified that age is an important variable in risk for depression among married and single individuals. Studies exploring whether seasonality is a cause of depression have yielded varying results. Authors of one large study report that prevalence rates of depression with seasonal patterns have varied from 1% to 12%, but in their study of 5,549 patients from primary care settings, there was no evidence of seasonal patterns for major depressive disorder. Another study found that a small but significant peak in depression symptoms occurred in winter months. However, the winter seasonal pattern was not stable over 20 years of following those patients. Major depressive disorder, MDD, is characterized by depressed mood or loss of interest or pleasure in usual activities. Evidence will show impaired social and occupational functioning that has existed for at least 2 weeks, no history of manic behavior, and symptoms that cannot be attributed to the use of substances or a general medical condition. The diagnosis will also identify the degree of severity of symptoms, mild, moderate, or severe, and whether there is evidence of psychotic, catatonic, or melancholic features. To recap, MDD includes the following criteria: single episode or recurrent. MDD can occur as a single episode or recur over time. It significantly impacts the individual's normal functioning. At least 5 of the following symptoms must be present for a minimum of 2 weeks. Loss of interest or pleasure in usual activities. Depressed mood. Decreased ability to concentrate. Decisiveness. Suicidal ideation. Inability to feel pleasure. Weight changes, more than 5% in 1 month. Changes in motor activity, increase or decrease. Characteristics of persistent depressive disorder, or dysthymia, are similar and perhaps milder than MDD. There is no evidence of psychotic symptoms. The essential feature is a chronically depressed mood, or possibly an irritable mood in children or adolescents, for most of the day, more days than not, for at least 2 years, 1 year for children and adolescents. The diagnosis is identified as early onset, occurring before age 21 years, or late onset, occurring at age 21 years or older. Premenstrual dysphoric disorder, PMDD, is a more severe form of premenstrual syndrome, PMS. It occurs in the week or two before menstruation and causes physical and emotional symptoms. Along with typical PMS symptoms like bloating and breast tenderness, PMDD can lead to extreme irritability, anxiety, and depression. Symptoms improve shortly after the onset of menstruation and become minimal or absent in the week post-menses. Symptoms of PMDD disrupt social, work, or school functioning and occur in most menstrual cycles. Essentially, PMDD can interfere with daily life due to its effects on mood, behavior, and overall functioning. Substance or medication-induced depressive disorder. This disorder causes clinically significant distress or impairment in social, occupational, or other important areas of functioning. The depressed mood is associated with intoxication or withdrawal from substances such as alcohol, amphetamines, cocaine, hallucinogens, opioids, phencyclidine-like substances, sedatives, hypnotics, or anxiolytics. The symptoms meet the full criteria for a relevant depressive disorder. Many medications have been known to evoke mood symptoms. Classifications include anesthetics, analgesics, anticholinergics, anticonvulsants, antihypertensives, antiparkinsonian agents, anti-ulcer agents, cardiac medications, oral contraceptives, psychotropic medications, muscle relaxants, steroids, and sulfonamides. Examples of medical conditions that influence depression include stroke, traumatic brain injury, thyroid disorders, Cushing's disease, Huntington's disease, Parkinson's disease, and multiple sclerosis. As discussed earlier, depression caused by medications or medical conditions is known as secondary depression. This can result from a number of drugs, either alone or in combination with other medications. Other medical conditions that lead to depression include an imbalance of the hormones estrogen and progesterone, which has been implicated in the predisposition to premenstrual dysphoric disorder, although the exact etiology is unknown. Deficiencies in proteins, carbohydrates, vitamin B1, thiamine, vitamin B2, riboflavin, vitamin B6, pyridoxine, B9, folate, vitamin B12, iron, zinc, calcium, iodine, lithium, selenium, potassium, and omega-3 fatty acids have all been associated with producing symptoms of depression. Other conditions include systemic lupus erythematosus and polyarteritis nodosa, cardiovascular diseases, such as cardiomyopathy, congestive heart failure, and myocardial infections, such as encephalitis, hepatitis, mononucleosis, pneumonia, and syphilis, and metabolic disorders, such as diabetes mellitus. Cognitive theory. Beck and colleagues, 1979, proposed a theory suggesting that the primary disturbance in depression is cognitive rather than affective. The underlying cause of depression is cognitive distortions that result in negative, defeated attitudes. These cognitive distortions arise out of defect in cognitive development, and the individual feels inadequate, worthless, and rejected by others. The outlook for the future is one of pessimism and hopelessness. The transactional model recognizes the combined effects of genetic, biochemical, and psychosocial influences on an individual's susceptibility to depression. Here's an overview of adult depression symptoms. Anergia, a state of being without energy. Anhedonia, inability to find pleasure in activities usually enjoyed. Anxiety and sluggishness, feelings of unease accompanied by reduced speed or alertness. Appetite changes, variations in eating patterns or food cravings. Bowel changes, specifically, experiencing constipation. Sexual disinterest, reduced desire for sexual activity. Fatigue, persistent tiredness, not relieved by rest. GI changes, alterations in gastrointestinal function, and pain, experiencing discomfort or aches. Further symptoms that occur in clients with depression also include sad appearance. The patient may seem visibly unhappy with a reduced emotional expression. Poor hygiene. There's a noticeable neglect in personal grooming and cleanliness. Movement and posture. The patient exhibits slower movements and a tendency to slump. Social withdrawal. There's a preference for solitude and avoiding social contact. Speech. The patient's speech may be slower than usual. Verbalization. There's a reduction in the amount of talking. Response time. The patient takes longer to react or answer. Here's a brief overview of the tools used for depression screening. Hamilton Depression Scale, a widely used clinical questionnaire to assess the severity of depression. Beck Depression Scale, a self-report inventory to measure the depth of depression. Geriatric Depression Scale, a screening tool designed specifically for older adults to detect depression. PHQ-9, a 9-item questionnaire used in primary care to screen for the presence and severity of depression. Clients with severe depression experience distress, which eventually disrupts daily functioning. These tools are essential for healthcare professionals to diagnose and manage depression effectively. Bereavement overload occurs when individuals experience so many losses in their lives that they are not able to resolve one grief response before another begins. It predisposes elderly individuals to depressive illness. Depressive syndromes in older adults are often confused by other illnesses associated with the aging process. Symptoms of depression are often misdiagnosed as neurocognitive disorder. Complicated grieving is defined as a disorder that occurs after the death of a significant other, or any other loss of significance to the individual, in which the experience of distress accompanying bereavement fails to follow normative expectations and manifests in functional impairment. Some interventions for clients experiencing depression associated with grief include antidepressants and therapies. Clients can participate in individual psychotherapy or group therapies. Please note that electroconvulsive therapy is used as the last resort. We will discuss it further under treatment modalities. As a nurse, your role in providing support to the patient is crucial. Be accepting of the patient and spend time with him or her, even though pessimism and negativism may seem objectionable. Focus on their strengths and accomplishments and minimize their failures, as this will help them in their recovery journey. Promote attendance in therapy groups that offer the client simple methods of accomplishment. Encourage the patient to be as independent as possible. Encourage the patient to recognize areas of change and provide assistance toward this effort. Self-esteem is enhanced by the ability to interact with others in an assertive manner. Of women who give birth, approximately 50 to 85% experience the blues following delivery. The incidence of moderate depression is 10 to 20%. Severe, or psychotic, depression occurs rarely in about 1 or 2 out of 1,000 postpartum women. Symptoms of moderate postpartum depression have been described as depressed mood varying from day to day, with more bad days than good, tending to be worse toward evening and associated with fatigue, irritability, loss of appetite, sleep disturbances, and loss of libido. These symptoms usually develop during the first few days following birth, but may occur later. Treatment of postpartum depression varies with the severity of the illness. Psychotic depression may be treated with antidepressant medication, along with supportive psychotherapy, group therapy, and possibly family therapy. Moderate depression may be relieved with supportive psychotherapy and continuing assistance with home management until the symptoms subside. Using information collected during the assessment, the nurse completes the patient database, from which the selection of appropriate diagnoses is determined. Some of the most important outcomes or positive mental health being for clients experiencing depression include safety. The patient has not harmed themselves physically. Emotional expression. They openly discuss their feelings. Optimism. A sense of hopefulness is present. Goal setting. They establish achievable goals. Activity engagement. New activities are being tried. Spiritual well-being. Their satisfaction and support found in spiritual practices. Health habits. Good sleep and eating patterns are maintained. These indicators suggest the individual is maintaining a healthy mental state and engaging in behaviors that promote well-being. Clients with depressive disorders are at high risk for suicide and self-injury. You can help them by establishing some achievable goals, such as short-term goals. Patient will express anger about the loss. Patient will identify coping strategies and rational thought patterns in response to loss. Long-term goal. Patient will be able to recognize his or her own position in the grief process while progressing at own pace toward resolution. Therapy, whether in a one-on-one environment, such as an individual psychotherapy or with a group or group therapy, can be beneficial to a patient suffering from depression. In cognitive therapy, the individual is taught to control thought distortions that are considered to be a factor in the development and maintenance of mood disorders. The generals in cognitive therapy are to obtain symptom relief as quickly as possible, to assist the patient in identifying dysfunctional patterns of thinking and behaving, and to guide the patient to evidence and logic that effectively tests the validity of dysfunctional thinking. Group therapy forms an important dimension of multimodal treatment for depressed patients. The element of peer support provides a feeling of security as troublesome or embarrassing issues are discussed and resolved. Therapy groups help members gain a sense of perspective on their condition and encourage them to link up with others who have common problems. Similar to group therapy, family therapy works with families of patients with disorders to resolve the symptoms and initiate or restore adaptive family functioning. The light therapy is effective treatment, beneficial for seasonal affective disorder, especially when combined with medication. Exposure to UV rays, patients sit in front of UV light, which mimics natural sunlight. Session duration, begins with 2 short sessions and increases to longer periods up to 30 to 45 minutes. Daily limit, typically, 1 30-minute session per day is recommended. Biochemical effects, stimulates the retina, reducing melatonin and boosting serotonin levels, which can improve mood. Light therapy is a non-invasive treatment that can help regulate mood-related chemicals in the. For light therapy, no individual session should be more than 30 minutes at once. ECT is the induction of a grand mal seizure through the application of electrical current to the brain and is effective with patients who are acutely suicidal and in the treatment of severe depression, particularly in those patients who are also experiencing psychotic symptoms and those with psychomotor retardation and neurovegetative changes. It should be considered treatment only after a trial of therapy with antidepressant medication has proved ineffective. Transcranial magnetic stimulation, TMS, is a procedure that stimulates nerve cells in the brain to treat depression. TMS involves the use of very short pulses of magnetic energy to stimulate nerve cells at localized areas in the neural cortex, similar to the electrical activity observed with ECT. Unlike ECT, the electrical waves generated by TMS do not result in generalized seizure activity. It is non-invasive and considered generally safe. Antidepressant medication is generally considered first-line treatment for severe clinical depression, but is also used in other depressive disorders. These include tricyclic, tetracyclic, and heterocyclic antidepressants, monoamine oxidase inhibitors, MAOIs, selective serotonin reuptake inhibitors, SSRIs, selective norepinephrine reuptake inhibitors, SNRIs, and SSRI-SNRI combination drugs. More detailed descriptions of these medications can be found in Chapter 4, including indications, actions, side effects, and safety issues. It is important to note that antidepressant medication can be lethal in overdose. Depressed, suicidal patients must be observed closely, and suicide risk assessed frequently. Please recall that serotonin syndrome is a serious drug reaction caused by medications that lead to high levels of serotonin in the body. Serotonin, a natural chemical produced by the body, is essential for nerve cells and brain function. However, excessive serotonin can result in a range of symptoms. Symptoms typically appear within hours of taking a new drug or increasing the dose of an existing one. They include agitation or restlessness, insomnia, confusion, rapid heart rate and high blood pressure, dilated pupils, loss of muscle coordination or muscle twitching, heavy sweating, diarrhea, headache, shivering, goosebumps. In severe cases, serotonin syndrome can lead to high fever, tremors, seizures, irregular heartbeat, Unconsciousness. Some neurotransmitters, such as serotonin, norepinephrine, and dopamine, are decreased in clients with depressive disorders. These neurotransmitters play crucial roles in mood regulation, behavior, and overall well-being. Consider how changes in their levels impact mental health. SSRIs, selective serotonin reuptake inhibitors. Examples: citalopram, fluoxetine, sertraline, escitalopram, and paroxetine are used to treat depressive disorders. Some adverse effects include nausea and vomiting, headache, insomnia, agitation, sexual side effects, and weight gain. Monitor for serotonin, a serious drug reaction caused by excess serotonin. Teach clients to avoid St. John's wort. This herbal supplement can interact with serotonin-related medications. Tricyclic antidepressants, TCAs, are also used. Example: amitriptyline. Be vigilant for orthostatic hypotension, a drop in blood pressure upon standing, which can happen to clients taking TCAs. Other antidepressants we discussed in previous modules include MAOIs, monoamine oxidase inhibitors, for example, phenelzyme. Teach clients to avoid foods high in tyramine to prevent a hypertensive crisis. Examples of tyramine-rich foods include aged cheese, wine, beer, coffee, and processed meats, and cold remedies. Atypical antidepressants, for example, bupropion. Unlike SSRIs, bupropion does not cause weight gain. It may suppress appetite and assist with smoking cessation. SNRIs, selective norepinephrine reuptake inhibitors, for example, venlafaxine and duloxetine. These medications affect norepinephrine levels. Patient and family education tips about antidepressants. The patient should continue to take the medication even if symptoms have not subsided, as the therapeutic effect may not be seen for as long as 4 weeks to 6 weeks. The patient should do the following. Use caution when driving or operating dangerous machinery. Drowsiness and dizziness can occur. Do not discontinue use of the drug abruptly. To do so might produce withdrawal symptoms, such as nausea, vertigo, insomnia, headache, malaise, nightmares, and return of symptoms for which the medication was prescribed. Report the occurrence of any of the following symptoms to the physician immediately: sore throat, fever, malaise, yellowish skin, unusual bleeding, easy bruising, persistent nausea and vomiting, severe headache, rapid heart rate, difficulty urinating, anorexia and weight loss, seizure activity, stiff or sore neck, and chest pain. Rise slowly from a sitting or lying position to prevent a drop in blood pressure. Take frequent sips of water, chew sugarless gum, or suck on hard candy if dry mouth is a problem. Maintain good oral care by brushing teeth frequently and flossing. Thank you for spending your precious time reviewing this module. Next, we will discuss self-harm in a separate presentation.